Thanks, Dr. DiMaria, for this excellent presentation. Made a little bit change. Dr. Mike Valentine, the current president of the American College of Cardiology, will be the next speaker, and he's going to welcome you first. Mike?
Well, thank you, Mahfouz, and thank you for all of you for being here from the American College. I'm grateful to have Tony DiMaria, who's a past president of the college, and of course Nanette, who was one of my true mentors and teachers early on. So she still apologizes that she didn't do a good enough job to make me any better, but she tried. So, but thank you for all. The college is grateful to be here again this year. We're grateful to have our colleagues from ABC here. It's a great honor to be working with you guys in prevention. We have a lot of exciting things coming up, some that I'm going to show on my talk in relationship to the ACC meeting coming up in March about prevention. So again, we're grateful to be here. And I don't do very well standing behind a lectern, and since this is a case study, I'm actually going to walk out there and see if you can answer some of these questions. So I'm going to see how much you've paid attention to your great speakers today, because you've had wonderful speakers yesterday and today. So I'd like to do this. If this is okay, let's to do it like this. So this is called secondary prevention, since this is a prevention meeting, and we're all trying to prevent disease in our patients. So a case-based study with new data and some trials expected at ACC 19. So I have no disclosures to this. And here is your case. And I will tell you that it's Friday afternoon at 4 o'clock. Very typical. This is your Friday afternoon patient. It's 4 o'clock, and the staff is getting a little antsy. So you walk in, and this is a 76-year-old woman. As you can see, she has a history of permanent AFib with brake control, and she's on an anticoagulant, which you'll see. She had a recent 928 MI and a drug-eluting stent through her circumflex. This is a 2.5 by 32, fairly small, long drug-eluting stent. She had moderate diffuse disease in her right coronary and her LAD. This was all about 7 months ago. After her hospitalization, she was seen by a nurse practitioner. And now she's seeing you for the first time after a quote-unquote 6-month visit post-PCI. Her meds, she's on an aspirin, she's on warfarin, and clopidogrel. She's on a beta blocker, an ACE, and a statin. She's on the atorvastatin 40. Her echo following this, that was not done with a handheld device, showed an EF of 45% and moderate MR. She has a creatinine of 1.8, potassium of 5.2, and her hemoglobin A1C is 9. She's still smoking, which of course doesn't shock you. And then you have these questions. What should her medical management include? What do the guidelines tell us to do with this patient, especially some of the newer guidelines? And then, what is best practice for secondary prevention in this patient? It's Friday afternoon, and you have 15 minutes. Go. So, okay, so what are the questions? Number one, which medicines should be changed at this outpatient visit? And I'm going to let you vote. Aspirin, clopidogrel, atorvastatin, ACE inhibitor. So which of you think, I want to see a show of hands now, you can vote, this is like Chicago, you can vote many times. So we're going to vote, number one, which of you think that aspirin should be changed at this visit? Okay. Which of you think clopidogrel should be changed or discontinued at this visit? Ooh, crafty. Which of you think atorvastatin should be changed at this visit? Couple. Think about. How many think the ACE inhibitor should be changed or discontinued at this visit? Okay. All right. Well, remember all the guidelines that you heard in the last 2 days about diabetic patients and lipids, and then we're going to talk about something a little bit different here. Okay, next question. What is the ideal length of time for triple therapy in this patient, given her risk-benefit ratio? 1 month, 3 months, 6 months, or 12 months. How many vote for 1 month for triple therapy? You? How many say 3 months? 6 months? Got a shy crowd. How many 12 months for triple therapy? All right. Well, then we have some data to review. And then, question number 3, what further recommendations for secondary prevention would you recommend this patient? Cardiac rehab, smoking cessation, depression screening, which we talked about yesterday, which we're going to review, and diabetic therapies, and all of the above. What's the answer here? All of the above. Good. Right now, each of you has an A. Okay. So this is some of the data. I showed this last year, so it's a little bit of a rehash. But double versus triple therapy, post-PCI, in patients who need this. This was the Roche trial. You look, this was published in Lancet in 2013. So look at those. This is TIMI major or minor bleeding. Look at triple therapy out to 180 days. Look at this, 40% at 180 days. And look at death, MI, CVA, triple versus double therapy. Can you see what kind of risk we put our patients at when we leave them on triple therapy? And you're basing this against the benefit that you're trying to do. So remember, even in the latest aspirin prevention trials, aspirin does good, but aspirin also causes bleeding. So you have to look at the risk-benefit ratio. And how about this? This is the Danish nationwide study, 9,000 patients of those who had 1 year after MI, PCI. And look at this. Look at MI coronary death for triple therapy and serious bleeding. Look at this. Look at the hazard ratio for triple therapy. Look at double therapy. If you do warfarin and clopidogrel, look at the risk here. And how about warfarin alone? Much better. So if you look, you're putting your patients at great risk the longer you leave them on triple therapy. And some even double therapy. So you really got to get this right, because the number of bleeds is substantial. And here are the guidelines. This is what the guidelines say, both the European and the American guidelines. If you look, these are focused updates. But look at this. Concerns about ischemic risk, triple therapy for 1 month, or triple therapy for up to 6 months if really ischemic risk. But how about concerns about bleeding risk? 1 month for triple therapy, and then some even say perhaps just double therapy alone. And there are trials. How about the United States? What do we say? High bleeding risk, low ischemic risk. One agent has to go at 1 month. Okay? No triple therapy past 1 month here. How about balance? Could be 1 month, could be up to 3 months, but no longer than 3 months. But how about high thrombotic risk of your stent and a very low bleeding risk? We'll give you the 3 months, but you should still discontinue one at a most at 3 months, even in this ACS patient. So here's one of your answers. And if you look, after 12 months, get them off all the antiplatelet drugs. Anticoagulation alone after 12 months for all these patients. See that? At 12 months, discontinue the aspirin and the clopidogrel to keep the patient safe. So what are the take-home messages for this patient, which you see every day? The take-home messages are, number one, double therapy has a lot less bleeding control. Number two, in all the randomized trials, double therapy, there is no glaring signal of increased stent thrombosis when you back off. So you're actually helping your patients to withdraw these medicines at the proper time. So the answer is, number one, keep triple therapy short as possible. Don't put your patients at risk. Stop medicines. They'll be grateful. Number two, double therapy is reasonable and high bleeding risk and perhaps average bleeding risk. Strongly consider the use of a PPI for GI protective. I realize that a a stroke is much worse than a GI bleed. But the emotional part of having a GI bleed, admitting the patient 4 units of blood, colonoscopy, it's still very painful. So protect them when you can. And last, please consider stopping all antiplatelet drugs at most after 1 year. At 12 months, anticoagulant. So then here's the next part of this patient. We've kind of gone, we'll go back to what secondary prevention ACS. Beta blockers, ACE inhibitors, high intensity statin, cardiac rehab, all class 1. All class 1. So you got that right. You said do them all. Exactly right. Oops. So next, just to make it easy, it's now Friday afternoon at 4:20. And you look down, and the hemoglobin A1C is 9. And just like we talked about yesterday, nobody's addressed it. So what are you going to do for this patient? Well, you've heard 2 talks, Dr. Ferdinand and Dr. Shahawi yesterday. Both talked about which of these medicines help in long-term cardiovascular prevention for this patient. Is it glipizide? Is it IMPA, as we say in the easy word, the SGLT2 inhibitor, metformin, or insulin? So which would you vote here? How many vote for IMPA, the SGLT2 inhibitor? Right, it should be 100% in this room. Remember, Dr. Ferdinand just said 2 hours ago, insulin is going to help for your high glucose, but it has no long-term cardiovascular benefit in the trials. Same for metformin and glipizide, but your SGLT2 will help in cardiovascular risk, up to 26%. So then, what did we learn in recent trials? How about AHA? Any of you who looked at the most recent data at the AHA meeting would say, is there new evidence for high triglyceride treatment? Let's say this patient's triglyceride were 200, 250. Is there any indication that lowering the triglycerides will help this patient long term? If the answer is yes, raise your hand. It is, yes, because the REDUCE-IT trial, 26% reduction in MACE for patients who went on Vascepa, which was abused. This shocked everyone because remember how much we had shown before? Fish oil, none of the omega-3s were showing dramatic impact. This was the first one that did, and we can't put the results just on the triglycerides. So it's an interesting trial that more is coming out. And then fish oil and vitamin D, no major improvement, nothing in the controlled trials that would say that made a difference in this patient. We did learn once again, if there's 3 vessel disease in this patient, who you said has a hemoglobin A1C of 9, what is the best form of long-term revascularization? Surgery. Surgery. Not multivessel PCI in the diabetic with severe pre-vessel disease. Another trial at AHA, surgery has better long-term outcome in the diabetic patient. And then you ask about depression. What information do we have on depression? And this is a great subject that you talk about more and more now as we treat elderly patients. So, does depression screening help in this patient? Well, this is an article from the Annals in November, a year and a half ago. If you do depression screening for these patients, they're at greater risk after ACS. ACS patients and heart failure patients, you said that, heart failure patients, really lower compliance and worse outcomes. Does it help to get them help? We're about to find out, and I'll show you. We do know so far in this study that we've shown documented quality of life improvement. We did. So in my practice now, I have a mental health social worker in our practice who works full time. And I will tell you, she may be the busiest person in the office now. She is good. Heart failure clinic needs her almost full time. Every different part of the office uses her. And she sees probably 7 to 8 different consults a day. So think about this, and I'll show you something else. Dr. Shalley wanted us to say at the ACC 19 in New Orleans, guess what? The prevention guidelines come out. So the 2019 ACC AHA prevention guidelines are coming out 6 weeks on Saturday at 2 p.m. These guidelines were produced in 1 year, which was very impressive for us, given our past history of taking too long to get the guidelines out. So they're coming out. What else is due at ACC 19? How about these 8 trials on prevention? These are interesting. So you've got the hopeful heart, 12-month primary outcomes in patients with comorbid depression. So we're going to find out. How about the second randomized trial of depression screening after acute coronary symptoms? So we're finally going to have some data about whether it makes any difference and whether we should be doing it perhaps on the front line. And then look at this, the wisdom trial. Maximally tolerated statins, adding more medicine. Comparison of 3 combination therapies in lowering hypertension and blood pressure in African Americans. This is going to be important. And then down here, one that I really look forward to, alcohol AF, the impact of alcohol cessation on atrial fibrillation. So all these are prevention trials, which really should give us more information at this meeting next year. So let's go back. Let's go way back. Apologies for going back through all these. So this patient, it's now Friday afternoon at 4:30, and you're late. Okay? Let's go back again. In this patient, which of these medicines should be changed or discontinued? Aspirin, 81 milligrams. She is now 7 months out, and she's on triple therapy. How many of you want to stop aspirin right now at this visit? Good. You should. 3 months should have been the maximum this patient should have been on aspirin. Now she is on clopidogrel and warfarin after you stop that. How long would you continue clopidogrel in this patient? 12 months total and then stop? Correct. You should stop double therapy in this patient at 12 months in June of this year and leave her on warfarin alone. Now, the new guidelines just came out May 5th. The next visit, maybe it's time to talk about warfarin versus a NOAC. Better outcomes. If you look, better outcomes in the guidelines that just came out May 5th. But remember, she's got a creatinine of 1.8. Okay? Her creatinine clearance is still probably over 25. So most would recommend that she continue her ACE inhibitor, or ARB, because she's a diabetic. Okay? And how many of you think leave her on the atorvastatin 40? How many would raise the atorvastatin dose here? Dr. Winger, my first teacher, Dr. Winger is correct. She is not on a maximum dose statin. Now, perhaps if you drew a lipid level on her and her LDL was 32, I'll give you credit. But remember, in LDL, no low is too low. So I would maximize her dose. I would stop her aspirin. I would consider stopping this at 12 months. I would double her atorvastatin at 40. And on the next visit, I would say we also need to talk about whether to change your warfarin to one of the novel oral anticoagulant drugs. So from that, thank you. You've been great students, and you've taught me as always in this course. So thank you.